The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
So, I'm going to apologise up front if I offend any medical administrators in the audience. And a lot of my comments are going to also apply in part to the growing number of non-clinician administrators who are in charge these days, as well as perhaps clinicians who don't know much about intensive care. And I want to be balanced about this because also this is a two-way street. So what are the issues? Well, really, it's a complex relationship between intensive care and medical administration. And it's very important that we communicate, but also that we persuade effectively. And the art of writing a business case is a basic tool, and this is something that particularly doctors are not very good at and could improve. Corporate memory is depressingly short, I find, and as a result it's important to make a paper trail. Hospitals are not efficient markets. They don't necessarily allocate resources where they should go, which means if we don't interface with administrators effectively, our patients miss out. So this is important. And one of the key problems is that I find not everyone really understands what we do. Attitudes can vary from the mystical black box to being regarded as back of house. So it matters because we've got a labour-intensive workforce, depreciating obsolescent capital. We cost a lot of money. We also are at the forefront of safety and quality, and we have a lot of data, which is very important, increasingly in an age of mandatory reporting and compliance. But administrators do want a return on investment. ICU is sometimes called expensive care. And so managing up and managing these expectations, I think, is also an important part of what we need to do. Now, it can feel like this, going and asking for more. And in fact, one medical administrator told me some years ago that, you know, Shane, the answer to any of your requests is always the same. It's X plus 1. Having said that, the other side of the coin is this, where you have charismatic leadership that leaves a trail of casualties behind it. And yes, those sorts of people are effective at breaking through and sometimes getting things done, but the solutions are personality dependent and are not enduring. So I don't think this is necessarily the best leadership style. So we've got to explain to the administration what we're about. Now, magical thinking is the enemy of the ICU director. We are pragmatists, and we understand that putting patients in the special room and doing nothing particularly useful to them doesn't usually result in good outcomes. This can lead, otherwise, to overutilisation of ICU and HDU, sometimes underutilisation. And there can be these blurred boundaries between the ICU and the wards. Not always is the funding model for intensive care understood. It's just expected that we'll get on and do it. And perhaps politically we're not that powerful, not that precious. Maybe we need neat targets like they have in ED to become an important issue or a pressure point. Now, one administrator said, Shane, it's all right. This is when I was asking for a refurb of our 20-odd-year-old unit. You're back of house. It doesn't really matter. So I found this slide that says that back of house refers to those departments or areas which rarely have staff to guest interactions. Well, we might be considered the equivalent of the janitorial department of the hospital, but we do interact a lot with patients and their families. So I don't think we're back of house. The Monty Python fans in the audience will remember this skit. Look, to some medical administrators, the gadgetry can be very impressive. But what we understand is that it's really about the people and the professionalism of those people. So it's about staffing. Another potential pitfall is that to a man with a hammer, everything looks like a nail. So to the modern-day medical administrator with an ICU and a MET system, everything can look like a problem to be solved with the above. This also can lead to overutilisation. There are a number of myths that HDU is some form of ICU light when you don't want to pay for HDU. that effective surgical programs and emergency services can coexist without compromise, never cancelling a case. Well, it depends on how much money you want to throw at the problem. That MET equals an automatic referral to me. That MET means that someone's actually critically ill, which they may not be. If we admit the patient to ICU, someone will pay. And that there are no opportunity costs. Well, of course, opportunity costs abound. Now, if we look at Apache scores, and if we were to assume a normal distribution, and they tend not to be normally distributed, but just for the sake of the argument, suppose they were, the reality of activity-based funding and how health funds work in the private sector is that perhaps the patients in the green box would attract funding. Often, and in particular if you have a risk mitigation strategy of parking patients in the unit, then your Apache scores may be skewed something like this, in which case the patients in the green box receive funding, but the patients in the red box don't under our activity and acuity models. I find this a particularly useful slide for crystallising the administrator's thoughts on the subject of using ICU as a risk mitigation tool. Now, Jeremy Kahn and Rebecca Gooch have come up with this concept, this matrix, and it's quite useful, I think, in framing our thinking, because the patient or target population for intensive care are these people who are very sick, who might die, but we can actually help. If you have a high bed availability, there is a risk of increased admissions of people who don't need us and frankly won't benefit. There's also a risk of admitting people at the end of life who aren't going to benefit even though they are sick. So to some extent, having an optimal number of beds may put some positive pressure on to avoid admitting people who aren't sick and don't need us, or those who are too sick to benefit. So this is an important conversation that intensive care needs to have with medical administrators about what the optimal bed platform should be. Now, there's an aphorism that in God we trust, all others bring data. We have to be able to write a professional business case and argue the facts and figures, including the dollars, and be persuasive about it. And in particular, having an executive summary which really states clearly what we're trying to achieve, because often the rest of it won't get written. So I think some financial literacy wouldn't go astray on our side of the relationship. And just talking to people like I'm doing now doesn't necessarily mean communication. Okay? Communication is about creating joint meaning. And if you want to be persuasive, you've got to be very clear about three things: what you're offering, where you're going, and why is it relevant. And don't forget the one at the bottom, because that is important. What's in it for me? Now, I've discovered that ICU directors, perhaps good thing, tend to outlive some medical administrators. But the downside of that is that we end up having the same conversations with a continual stream of new administrators about the same things. So immortalising some of what we've decided in corporate memory on paper or electronically is not a bad idea, and I'll come back to that a bit later when I talk about the annual report. In business planning, we use something called the PESTEL Framework, which includes these political, social, environmental, economic, technological and legal dimensions. Now, these are also all important areas to consider from the healthcare perspective. Now, healthcare is a classic example of an industry which has strategic customers. Okay? Strategic customers, in fact, can create a conflict of interest. In the case of medical administration, there's a conflict of interest between keeping the VMOs, the surgeons, the proceduralists happy on the one hand, versus the patients who perhaps are the real customers on the other. Now, I've also discovered, sadly, that intensivists are not considered strategic nor customers. In the exercise of power and authority, it's important to understand the level of interest. Now, medical administrators are quite powerful, even if they tell you otherwise, although they may well be constrained by budgets, in fairness. It's tempting, perhaps, to try and fly under the radar and just keep out of their way. But I would suggest that it's probably more important to engage them and keep them interested, in which case a more fruitful relationship may develop. So I think it's about informing them and being involved. What are the bases of power within an organisation from our perspective? Well, ICUs are very labour intensive. We possess a lot of technical knowledge, and in effect we control a monopoly. So that's a basis for power. But the challenge really is to move towards creating a higher degree of influence, cultivating influence, being more involved in the life of the hospital, and perhaps rising up the hospital hierarchy, not for the sake of power, but to be able to advocate better for our patients and on behalf of our services. This is really hard. Negotiation is going to be part of what we have to do, and it is a technical exercise which can be learnt. It requires people to do their homework. One of the key things is about growing the pie to avoid a zero-sum game, and that's hard in modern healthcare. But we should be striving to identify innovations or reforms in healthcare that through investment will actually save money. You do need to know what is your BATNA, your best alternative to a negotiated agreement. This is your fallback position if you can't arrive at an agreement. And there are pitfalls to negotiation, but I believe that most medical administrators, if you treat them fairly, reasonably, act with integrity and honesty, they will be more than reasonable in return. But you should not be afraid to ask for what you want, and you must not settle for less than your patients need. Be clear on that. Time is money and effort. So if you're going to fail, fail quickly. Okay? One of the problems is that intensivists, and perhaps even worse, anaesthetic intensivists, share the personality trait of many anaesthetists, and that's obsessionality. And so there can be a tendency not to move on to the next issue. Clearly, intensive care is involved in the governance of the hospital, and particularly around Standard 9, soon to be Standard 8. We should have a direct voice in the hospital executive. We're not just a plaything, in particular for the division of surgery. And I found that integrating the ICU M&M into the hospital executive reporting is critically important. Most of the adverse outcomes in the hospital will congregate in the ICU, even though we didn't cause them. And smart medical administrators know that if they want to have their finger on the pulse of the hospital, they need to know what's going on in the ICU. Disunity is death. Intensive care, as in any other group endeavour, is very much dependent upon its cohesiveness. And sadly, we don't, as an industry or as a group, necessarily have the best reputation for harmonious working relationships. If we can't get our act together and be on one page, we have no hope of being able to interface effectively with the medical administration. I mentioned before the value of writing an annual report. I find this is quite useful to solidify our thinking on what the department does, what we've achieved, to put that in front of the administrators, to have it immortalised in paper, and it becomes a very rich document, both for data and to underpin dialogue into the future. It takes a lot of time, it involves a lot of effort, but it impresses and it is worthwhile to be taken seriously. Now, just to sort of close, what if we wanted to write a business case? How could we go about it? Let's propose a critical care outreach service. Now, this is going to cost money because it will be largely involving nursing staff, whereas the Met system, increasingly, as you know, is unfunded in this country. You need a business model canvas. Now, this is a semi-graphical way of putting on one page the key components, what you're going to do, what's the value proposition, who benefits, what are the finances. It's important at the planning stage to test the logic before you go any further and waste anyone's time, especially your own. There must be a strong value proposition. Now that, in the case of critical care outreach, may be reasonably easy to argue. It may prevent unnecessary ICU admissions. It may result in earlier management of deteriorating patients, improved level of care and outcomes, greater staff and patient and family satisfaction. Okay? Collaborative relationships being developed between the ICU and the wards. And remember I said before about in God we trust? Well, you need data and a solid literature search to underpin the scientific validity of what you're offering is important. They'll expect that, and for critical care outreach there is some evidence. Medical administrators are particularly aware of compliance requirements. So critical care outreach cuts across a number of these standards, 1, 2, 6 and 9. Okay? So it's certainly something that's going to be relevant, particularly if accreditation is coming up. Now, critical care deterioration, poor safety is expensive. I mentioned this morning that it may add $100,000 to the ICU costs in the paediatric setting, and recouping a relatively small or avoiding a relatively small number of these events could cover the costs of running a rapid response system. But there's also the important point of reducing the medico-legal compliance costs, reporting, financial penalties for the hospital, particularly in this modern era. If you cost out using annuity calculations over a 5-year period, the potential cost of a round-the-clock nursing model, you might come up with a figure of 2.6 million or thereabouts based on standard awards. That's going to scare people, but saving as few as 5 critical events per year could potentially recoup those costs. That's plausible. Finally, you've got to pitch it after having done all this good work, otherwise it's wasted. So that means a proper business case with financials, an executive summary, answer those classic questions of who, what, when, why and how, and in particular what's in it for me. And some of it might be compliance, some of it might be feel good, some of it might be actual dollar savings. But the other thing we have to do is we have to create a sense of urgency, a call to arms to do something. Otherwise it becomes another report that in my experience sits on the shelf and collects dust. And so to some extent this will rely upon your personal advocacy. So in conclusion, there need to be healthy relationships and mutual respect. We have to be good financial stewards and advocates. We can't just be Oliver asking for more. We've got to put our own house in order first, and we should try to negotiate as partners to grow the pie. Thank you.